morning, colleagues. We will be starting our program shortly. We are in the right place. It is a webinar by the Department of Health. We are just putting in now the head of department and the MEC for health. Our guest is already here, Dr. Khanya Msomi.
Hi, Dr.
Morning, MEC. We are now live, and we are just trying to get HOD in.
Good morning, Mapisa.
Yes,
good morning to the MEC. Good morning to Dr. Msomi and everybody in the meeting.
No, thank you very much. We are happy that we are having the actual doctor. I'll just state the program. It's a short program so that we can start. We will have a program director who will be Dr. Tshabalala with our HOD, and he will open for us. Then we'll get you welcome, the background and the purpose of this webinar from MEC. Then we have a guest speaker, which is Dr. Nokukhanya Msomi, who will also then speak on the topic will be vaccine development as it pertains to viral infections and COVID-19. And then we will have engagement by the media after that, and they will allow also the public to also engage us and have inputs from different stakeholders. Then after that, we will get the responses from the guest speaker, MEC and HOD. Then we'll close after that. I'm just stating that so that we can start the program right away. I'll then hand over to HOD of the department, Sandile, Tshabalala, to take us through.
No, thank you, Mr. Mapisa. Good morning, MEC. Good morning, Dr. Msomi. Good morning to the attendees of this meeting and the webinar. But more importantly, thank you for attending in this important meeting where the MEC and Dr. Msomi will be clarifying a few things which are worrying the MEC, the Premier and the government of KwaZulu-Natal and government of the country in general about the issue that pertains to the vaccination that is coming. As Mr. Mapisa has said, the program is going to be very short. We are going to have the MEC welcoming all of us and giving us the purpose of this meeting, after which we will allow Dr. Nokukhanya to just speak to us about vaccination. We then will have a discussion after that. So may I take this opportunity, MEC, and call you to the stage to give us the background, give us the purpose, and also the opening of the meeting with your own remarks. Thank you, MEC.
Good morning, ladies and gentlemen. Thank you very much for being part of this webinar today, and the intention and purpose of this webinar really is to deal with the issue of the vaccine, the COVID-19 vaccine that the whole country is talking about, but not just the country, not just South Africa, the whole world has been abuzed by the issue of vaccines. South Africa is just at the tail end of that particular conversation. We have realized over the past few days or few weeks that there has been a lot of dissemination of false information about COVID-19 and the COVID-19 vaccine in particular. And then we decided to organize weekly information sessions or weekly information sharing sessions, or what you might term webinars, starting from today, so that we are able to share information where it's necessary for us to do so. Because so little was known about COVID-19 when it emerged, people became vulnerable to narratives, or have become vulnerable to narratives that are misleading and therefore extremely dangerous. In the absence of authoritative, clear information, false information always finds its way to the top. And
I'm sorry to disturb you, MEC.
Yes.
I'm sorry to disturb you. Your camera is off.
I was saying we therefore decided to have these information sharing sessions starting from today. We are hoping that we will make them weekly, or as and when it's necessary for us to be able to do so. I indicated that because so little is known about COVID-19, we have had so much misinformation going the rounds to a point that where no authority is coming up or clear information is being given to our people, false information becomes the gospel truth. We are therefore engaging the public in this manner in order to ensure that our people are empowered with facts that can help them to become resilient against misinformation. False information on COVID-19 is spreading at an alarming rate, and we have seen that happening over the past 9 or 10 months, making it more difficult for the public to identify and consume only verified facts and advice from trusted sources. And the fact that all of us are now beginning to be very active on the different social media platforms, because the social media platforms are meant to inform the society and to make sure that the society gets the proper information, but it has not happened in that particular fashion. We have noted with serious concern a number of videos, voice notes, posts, and messages on social media with misleading rumors about 5G communications and COVID-19 vaccines in particular. While the country is engaged on a process of procuring inoculation for our people in a bid to fight the pandemic, a number of people are expressing anti-vaccine sentiments. And it is so unfortunate that sometimes those people include those in higher offices, such as political leaders and some who are working for government. Not just them, we've also seen in the past few days that some that have social influence or are exercising influence within our society have also indicated or are expressing this sentiment, which is quite unfortunate. We believe that if the battle against COVID-19 is to be won, it is imperative for the public to be suitably informed and have the ability to recognize and disregard false information, and instead act in a safe and responsible way at all times. We are therefore appealing to the public to collaborate with government in our fight against the spread of fake news, so that we are able to deal with the COVID-19 vaccine once and for all. We are calling upon the people of KwaZulu-Natal to work with government towards addressing the infodemic of false information about COVID-19 and help us bust all the myths surrounding COVID-19. We will engage and work with numerous sectors. Here we are talking about your labor, business, politicians, traditional leaders, and the religious sector or community in particular, to clear up some of the conspiracy theories being spread about both COVID-19 and its vaccine, while ensuring that accurate information on vaccines is disseminated. The fear of the unknown is understandable, but it should not be exacerbated by false information and lies. It is a fact that over the years, vaccines have been used to eradicate diseases such as smallpox and polio in our country. Children get vaccinated routinely against many diseases such as mumps, measles, rubella, and travelers are often vaccinated against diseases like yellow fever. Those of us who are my age and younger will know that almost once a baby is born, they have to go to a clinic almost every other 2 months or every other month, depending on their age, so that they get vaccines. Now, these vaccines are no different from the vaccine that we are talking about today. These vaccines are meant to eradicate the diseases that I've just mentioned, and all of us religiously make sure that our children get this vaccine. Now, we do so because we know that they are in the best interest of our children, and this particular vaccine that we are talking about is no different. COVID-19 crisis has caused massive upheavals across the globe, and no nation has been spared. A vaccine represents the best hope to save lives and to restore our way of life. Many governments have therefore entered into direct talks with vaccine makers to ensure a timelier supply of vaccines. Our government is committed to saving the lives and livelihoods of our people. The fastest way to return to our way of life is through ensuring that the majority of the population is protected from the virus. Vaccines are the simplest and most effective way of doing this. At this stage, we would like to categorically dismiss the rumors that and the myths that 5G network causes the coronavirus through radiation. And I'm very happy to announce that the Premier is also going to be hosting his own webinar. The Premier of KwaZulu-Natal is going to be hosting his own webinar on Friday that is going to be addressing the issue of 5G network, what it is, and how that, and the fact that it does not have a role at all to play in the COVID-19. The World Health Organization has made it clear that viruses cannot travel on radio waves or mobile networks. It is also a fact that COVID-19 is spreading in many countries that do not have the 5G network. So we request that our people, when they get the information, they are able to sift through the facts. If they are able to sift and find facts within the rubble. However, we will expand more on this topic, like I said, on Friday when the Premier speaks to it. The fact is that COVID-19 is spreading through respiratory droplets when an infected person coughs, sneezes, or speaks. People even sings. Even when people that are infected sing, then the virus is spread. People can also be infected by touching a contaminated surface and then touch their eyes, their mouth, or their nose. We also want to dismiss the mark of the beast 666 myth that has been going around. There are messages, videos, and voice notes that are perpetrating that vaccines have the mark of the beast, which is 666. This is not true. Vaccines are made to save lives and are developed through technology. They have no connection with any religious organization and cannot be infused with spirits, demons, or other abstract ingredients. There is no conspiracy to possess, bewitch, or control anybody. Our guest today, who is also a specialist on vaccines, will share more light with us on how vaccines are developed. We are talking about Dr. Nokukhanya Msomi, who is the head of Virology department at the University of KwaZulu-Natal. She also works at the Chief Albert Lutuli Hospital, NHLS Pathology Section. Dr. Msomi is well versed on this topic as she is going to take us through the vaccine development as it pertains to viral infection and COVID-19. We approached her to give us facts about how vaccines are developed and dispel the rumors that are on the public domain on vaccination and vaccines in the province of KwaZulu-Natal in particular. We have to work together at all levels, individuals, communities, society, health system, and government, to resist misinformation, act on and propagate accurate health guidance to flatten the pandemic curve. Working together, let us identify and report the potential wrong, misleading information to deal head-on with the spread of inaccurate and harmful information during the pandemic. We are warning the perpetrators, and we decided to provide proper information first before we get to the issue of the security cluster or bringing in the security cluster against the perpetrators. However, we are warning the perpetrators now to desist what they are doing or face the mighty hand of the law. Anyone that creates or spreads fake news about coronavirus COVID-19 is liable for prosecution. It is very important for all of us to verify the information that we receive before we share it in any platform. Fake news can be reported through the website that is called real411.org, or you can call a WhatsApp line that is 067-966-5015. The Provincial Department of Community Safety can also be reached on 063-697-9569. Having said that, I do want to indicate that the Minister has been speaking about the vaccine in the past few days, and at this point, the Department of Health, led by the Minister, is preparing for the spread or the distribution of the vaccine. And the Minister, together with the leadership at a national level, decided that because our health workers are our foot soldiers, it makes sense to actually start the vaccine with them and then disseminate as we go further. So we'll start with the health workers, go to those that are elderly and those that have comorbidities, and then the rest of us will follow. I also want to indicate and emphasize the point that this vaccine is not, no one is going to be forced to actually take the vaccine, but we are appealing to our people because we believe this is what is going to save their lives. That when the time comes, please come forward and allow yourself to be vaccinated, so that, as the president indicated, we have a community that is protected from the vaccination. As soon as the distribution of the vaccine, or as soon as the vaccine is ready and has arrived, we will then have another discussion with yourselves on the plan and the program that we are going to follow in relation to the vaccine or the vaccination in detail. And those of us, for some people that travel, will know that when you travel to other countries, you often have to get immunized for something that is called yellow fever. And that yellow fever, for you to be immunized, you also have to have a particular card that is where it's going to be noted that you have been immunized for yellow fever. We believe that for this particular vaccine, we will also have something similar to that. But once the vaccine is here, we'll then have an information session that is going to be detailed, that's going to talk to where the vaccine is going to be supplied and who is going to start and what are the logistics that are going to be relating to that. As the province of KwaZulu-Natal, we are ready to start with the vaccine as soon as the minister and the National Department of Health has received it. With those words, Ntokozo, I wish to welcome everyone that is on this webinar and really appreciate the fact that Dr. Msomi has given us her time to come and talk to us and make it clear to us what is it that we are dealing with and why should people not be worried about the vaccine. I am hoping, Ntokozo, that we will also have an opportunity where we engage with Dr. Msomi again, but now in isiZulu, so that the majority of the people of KwaZulu-Natal also get to understand from the horse's mouth what this vaccine is about. So I hope on Friday, when you have your lunchtime chat, Dr. Msomi might avail herself so that we are able to engage with the general community there in isiZulu, so that they also get to hear it firsthand from herself, what this vaccine is and how our vaccines develop generally, so that we all have similar information and understanding on the issue of the vaccine. Thank you very much, Ntokozo. Thank you, HOD, and welcome Dr. Msomi to this platform. We really appreciate your opportunity. Thanks, Ntokozo.
Thank you, MEC. Thank you for the opening and the words of wisdom that you've given us. But MEC, you also have taken my responsibility of introducing Dr. Msomi. I'm not going to introduce her anymore. You have said, MEC, that you want us to hear from the horse's mouth. So I'm not certain whether I'm introducing Dr. Msomi or the horse, but let me introduce Dr. Msomi and allow her to give us her wisdom in terms of vaccine development, but also in particular in terms of this particular vaccine that we're speaking about. Thank you, Dr. Msomi. You're on the floor.
Thank you very much, HOD Dr. Tshabalala, and many thanks to our MEC Simelane-Zulu for a great welcome. And I'd also like to greet all members of the community that have joined this webinar, our colleagues in different sectors of health and the press, and the general public as well. I especially want to thank the Department of Health for this initiative, which I think is quite crucial in educating our communities and in demystifying or debunking a lot of the myths that we are seeing in our social media platforms that are really concerning and are driving vaccine hesitancy amongst our communities. I am very much aware that the audience that we have today is quite diverse. So I will try in my presentation to really focus on the very basic or fundamental concepts as far as vaccination is concerned in viral infections and COVID-19 in particular, and to try and address any questions that our participants and the audience may have regarding vaccine development and vaccine safety. I hope everybody can see my screen. So basically, I'll try and, like I said in my introduction, to focus my presentation at a very basic and fundamental level, so that we're all on the same page and we understand exactly what goes into developing a vaccine and traditionally how it has been done and how it has differed specifically for COVID-19, which may be a reason why there is a bit of a hesitation from the general public. So just to start off with, I'll explain some basic concepts in vaccination regarding immunity and actual vaccination. So immunity, when a person is considered immune, immunity refers to the protection that is gained against an infectious disease of any form. And once a person attains immunity, it means once they are exposed to a pathogen that causes a disease, they will not develop disease. And this is because the immune system would have been primed or forewarned to produce an immune response that protects the person from an infection. Now, how is this immunity attained? It may be attained through a vaccination, which is the topic of today, but it can also be attained through a natural infection, and I'll just touch on that as we go further. So a vaccine is the actual preparation that is given. Usually a vaccine is mimicking what a natural pathogen or a natural infection-causing bug that would cause a particular infection, so that the immune system learns to respond to this particular a pathogen. And once a person receives this vaccine, subsequent infections then do not result in disease, and a person who's vaccinated is protected because of a vaccine. Vaccination is the actual process of introducing the vaccine into the body to produce an immune system, so to teach our immune system to develop responsive and specific immune cells so that the person is protected against specific disease. A term that is commonly used interchangeably with vaccination is immunization. But immunization is actually the entire process by which a person becomes protected through vaccination. And like I said, this is sometimes used interchangeably with vaccination. Now, immunization, we normally refer to it, like I had said, that you may attain immunity through natural form, natural infection, or through vaccination. So we refer to these two different methods of immunization as active immunization versus, as active immunization, where a natural infection is attained, resulting in immunity developing, or immunity developing following vaccination. These two are referred to active immunization, which means there was an active infection resulting in attainment of a state of immunity. There is another way of protection or immunization being attained passively. In this way, where a person, either because they have a poorly developed immune system or they have an immune system that is not able to respond on its own, in the case of people with severe diseases or infants or neonates, passive immunization may occur. Here, there is a transfer of immunity temporarily because of a person, in the case of a mother to child, a transmission of passive immunization, a mother who would have been exposed to an infectious agent develops their immune system and they confer that immunity to the baby passively. And that usually protects the baby in the first 6 months of life. Artificially, this can also be done by using serum or blood from people who would have been exposed to a similar pathogen in the past and have recovered and developed antibodies that are able to fight the infection. These antibodies can then be used to passively immunize people who are very sick and who cannot develop their own immunity. So that clarifies the active versus passive immunization. So why do we go the route of immunization or vaccination as opposed to just letting people get naturally infected and attain immunization that way or immunity in that way? Obviously, because the consequences may be deadly. So the vaccination process tries to mimic what a natural infection would ordinarily do, in that the first time a body encounters an infectious agent, it takes long for the body to mount an immune response that is not only specific, but also effective against a particular pathogen. And during that time, disease may be so severe that a patient may succumb. So by giving a vaccine, we're trying to shorten that response time, in that when a person is given a vaccine while they're still healthy, the body is primed or is taught how to respond to that particular pathogen, so that the next time they encounter a similar pathogen, the response is quicker. So they respond faster and counteract any invading infectious agent or pathogen. And they respond also drastically, so that the infection is overpowered and the person does not develop disease or develops a dampened cause of disease, which is what we're trying to achieve. And so by doing this, the goals we're trying to achieve by vaccination is to, depending on which particular vaccine is used, is to try and develop a very specific immune response that is directed, and it's fast and it's efficient against a particular type of disease-causing organism. And when that is done, it prevents infection, or it limits the severity of disease. So that's the main goal of vaccination, is to induce that vaccine-specific immune response to prevent infection or make it less vicious or less deadly in some unfortunate cases. Another important goal, which I'm sure people have heard through various forms of media, is the concept of herd immunity. I know when we think of herds, we're thinking of a herd of cattle. But the concept here of herd immunity, which I'll try to unpack in my subsequent slide, is achieving herd immunity is one of the goals of the whole vaccination process. And once immunity of the herd or the community is attained, then the infection, the chain of transmission of infection is broken, and the disease does not set up in that particular community. So this shows that vaccination not only protects the individual who is vaccinated, but the more people are vaccinated, the protection is conferred to the entire community through herd immunity. So we get both individual and public health benefit, preventing and reducing the spread of infection. The ultimate goal, obviously, is we would all like to live in a utopian setting where there is no disease and there is no illness. But we're not yet close to that. But the more we take measures to prevent infection, like vaccination, the more that goal will be achieved. So the ultimate goal will be to eliminate disease altogether and eradicate disease from the face of the earth. And we know that precedence has been set towards this. We know that smallpox has been eradicated from the face of the earth, and we no longer need to vaccinate against smallpox because of a successful vaccination program. So this is always the plan with vaccination or with any preventive measures, in that the ultimate goal is to eliminate disease and illness from the public. So just to try and sum up how we define what herd immunity is. Herd immunity is basically protection that is offered to people who are not immune. So individuals in a community who are susceptible to infection, because the transmission of infection is disrupted by those who are immunized or who are immune. Depending on the type of infection that we're dealing with, depending on how successful it is in attacking what we call a reproductive number or a hit rate or an attack rate, different diseases or different infectious agents require a different level of vaccine coverage to achieve this herd immunity. Models that have been done for the coronavirus disease is that to achieve herd immunity against COVID or against the SARS coronavirus 2 is to get vaccine coverage of at least 67% or roughly 70%. Okay. So going back to the concept of herd immunity, which the MEC alluded to first, in that even though not everybody is forced to get vaccinated, we are all encouraged to get vaccinated because protection, similar to masks, protection is not only to the individual but to the greater public. So if more people are vaccinated and are immune, then the general public is protected. In this graphic here, we're trying to illustrate this point of how does herd immunity work. Consider here this groups of communities. The blues are the people who are healthy but not immunized. The orange are the people who are healthy but immunized, and the red are the people who are not immunized and are sick and contagious. So consider a population like ours in January 2020 when the news broke, December 2019 and January 2020 when the news broke of coronavirus infections, and there were very few cases of corona that were imported. Because most of us were vulnerable. So we were all healthy, but we were not immunized, so we were susceptible to the infection. Very few infections. In this case, the illustration is made by only 2 people in that community who are sick and contagious. But because there is fertile ground, no one is immunized, and the chain of transmission is very easy from this one person to all the people around them. And in that way, the disease is spread through the population, resulting in what we're currently seeing here with community-wide transmission. And this usually occurs when people are susceptible because they are not immunized or they are not immune. The second illustration here shows a different scenario where still you have the same 2 number of people who are sick and contagious, but you have very few people immunized. So you have a handful of people immunized in the community. Still, because the chain of transmission can still occur between some members of that community, the disease still continues to spread through the population, and you get the majority of people becoming sick and immunized. Hence, the whole concept of the more people that are immunized, the more the population is protected. And in the last scenario, when most people are immunized and remain healthy, even with 2 people remaining infectious and sick, then the disease transmission the chain of transmission is broken and disease spread is constrained, and you don't get widespread infection. And this is what we're trying to achieve with vaccination through herd immunity. Another discussion that we've had in the early days of around the first wave of coronavirus infection in our country was the issue of preventive measures that were put in place to try and curb the spread of the infection, in that there was worry that with the severe lockdown measures, we were losing livelihoods because the economy was impacted, and we were also losing lives. What the WHO has done recently was to do some sort of analysis to see how have vaccines over the years. Here, this analysis looks over a 20-year period between 2001 and 2020 in low and middle income countries, which are supported by the Global Vaccine Initiative, which provides vaccination in countries that cannot afford to procure their own vaccines, and to try and see with an intervention like a vaccine, how does it translate to improving not only averting the number of people that die or succumb to infectious diseases, but also in thriving of the economic performance of the country and social thriving in general. And this is very self-explanatory in this graph, in that between the year of this dark green bar shows how much economic and social value was gained. The lighter shade shows the averted cost of illness, because we now know that how expensive it is to put a person in an ICU or to give treatment once people get disease. And lastly, obviously, the ultimate cost of how many deaths are averted. And you can see over the years, as the Gavi initiative of providing vaccines in low and middle income countries increased. So you could see that as more vaccines were given, more lives were saved, because a lot of deaths were averted. And also there was economic thriving in all these communities. And this drives the point of that we are both saving lives and saving livelihoods through vaccination. Hence, everybody should really be rallying behind the initiative of getting our communities vaccinated. So what goes into a vaccine development, and how has it evolved over the years? So for viral infections, generally, vaccines have always been the cornerstone in the control of viral infections. I'm sure we are aware that there are not many antiviral drugs as opposed to antibiotics. And that is because it is very difficult to treat and cure a virus. So vaccines have been phenomenal and have been the cornerstone in the control of viral infections, in that prevention is always better than a cure. And this dates back to donkey years. Back in the 18th century, I think around 1767, the very first vaccine against smallpox using the cowpox variolation process was shown to be effective in preventing transmission of smallpox. And from that knowledge, dating back to the 18th century, our knowledge and science has improved in improving the ways of vaccinating using more sophisticated methods of growing. Once we established methods of growing viruses in the lab in cell culture, you could find ways of changing how the virus behaves and giving an attenuated virus or kind of a disabled virus as a vaccine, because it doesn't cause as much disease as the natural infection, or inactivating the virus completely and so that it doesn't cause disease. And those methods were the earlier methods used in the 19th and still being used throughout the 20th and 21st century as methods of vaccines. And a lot of the vaccines that we are using routinely against rabies, yellow fever, the poliovirus, which is also en route to being eliminated, the measles virus, mumps, rubella, chickenpox, and the seasonal influenza virus have all been vaccinated using those methods and continue to be used currently. But like everything, like technology improves, also the biotechnology has advanced, and now we have newer molecular biology-driven technology measures that have revolutionized the way that vaccines are produced. And in the 21st century, we're seeing now that most vaccines that would have been produced using the older culture-based systems can be developed using this molecular biology, or what's sometimes referred to as genetic engineering based methods, in producing vaccines faster, that are efficient and are very targeted. And we're seeing that in vaccines that we are already using in the general public. The human papillomavirus vaccine that we're currently using, inoculating our young girls and boys against cancer, the rotavirus vaccine against diarrhea in children, the hepatitis B virus, which causes severe liver disease and sometimes liver cancers, other hemorrhagic fevers like dengue and Ebola, which are severe devastating diseases, have benefited from these molecular biology-driven vaccines, and a lot of diseases and death have been averted because of these processes. So that same technology has been applied now in the developing of the SARS-CoV-2 virus. And that is why we're seeing such rapid and fast entry into the market of these vaccines that has not been seen in the past, because of how advanced the technology has been over the years. So this slide tries to illustrate how these particular vaccines, I just made an example of the two, the hepatitis B vaccine and the human papillomavirus vaccine, in that the whole virus, so consider this being the hepatitis B virus, it's not the whole virus that is used as a vaccine. A small segment of the gene segment is used, isolated, and you can create only that part of the virus that induces or that the immune system recognizes, and you use that as a vaccine or immunogen, and it helps to prevent against acquisition of hepatitis B. And this works very well, and it's even given at birth. So if something developed in that same fashion is given to neonates at birth, it surely is safe, and we've already accumulated enough evidence that there aren't the severe side effects that people are concerned about because of these genetically engineered or molecular biology-driven types of vaccine. Similarly, the human papillomavirus also uses the same concept, in that it only takes the small part of the virus, which is the envelope, and creates that and introduces that into the body. And that is what primes the immune system, and it's given, and through that you're preventing cancer. So I hope this drives home the point that these type of vaccines are in use, are effective, and they are considered safe. So traditionally, a vaccine does not enter the market, or does not reach human stages from the lab straight to human stages. It goes through rigorous steps in development which ensure that a vaccine is safe and it works efficiently. We have studies that are done preclinically, so in the lab before it's introduced to human beings. And here it's normally tested in cell culture methods, or it's tested in animal studies to see if it is safe first and foremost, because it has to be safe also for the animals on whom it is tested, and that it is efficacious. During this type of preclinical studies, also challenges can be done in challenging the animal with the actual pathogen to ensure that the vaccine does work in that environment in the preclinical stage before it is introduced to the human being. And then after that, various phases, phase 1, phase 2, and phase 3 of clinical trial, different parameters are tested to see how well these vaccines work. Starting with small groups, phase 1 trial will look at very small, healthy population group to see if the vaccine continues to be safe in human beings as it was in animals in the preclinical studies, and if it is also, if it can be used. And this is done on small numbers of healthy adult volunteers. Once it passes that phase or that step, it then moves to a next phase. And here, it's given to a larger group of also individuals who have similar characteristics for whom the vaccine is intended. So that it not only is safe, but it is also effective against the targeted people. And the same level of rigorous testing is done, safety is assured, efficacy is assured. And once that has been achieved, and then another phase of clinical studies gets done. And here it's given at high numbers, up to thousands of numbers. And here we're trying to establish if it wasn't just an isolated event in a small group of people, if the same type of findings can be replicated at higher numbers, because obviously once it's rolled out to the community, it will be at very high numbers. And only once a vaccine passes all three of these clinical trial studies can it be introduced to the human population. And even then, it does not stop there. So once a vaccine has been approved or authorized or licensed to be given to the community, continuous monitoring is done to monitor for any adverse events and to also see if there are any long-term effects that could not have been seen during the study period. And these are all the measures that are put in place to ensure that vaccines are safe and can be trusted and used in humans. Okay. Over the years, like I had said, as the technology progressed, the traditional vaccine development has taken long periods of time because firstly, to take either a vaccine or a drug from the lab to the general market is very costly. So generation of funds and generation of money sometimes restrict how fast a drug progresses. But also the technology in the past has also been such that the methods that are used are slow, resulting in drugs reaching or vaccines reaching market approval stage or distribution in the market a bit longer, up to 10 years in some cases. What we have seen with COVID, obviously with COVID, it was a pandemic which spread rapidly. There was an explosion of knowledge and scientific sharing of information, which resulted in a readily available information, readily available technologies, which has been developed over the years. Remember, before SARS coronavirus 2, there was SARS coronavirus. So a lot of research has been put or done to try and find vaccines against various other coronaviruses and various other infectious diseases. So the know-how has been there. And to try and expedite the development of this vaccine, a lot of these studies, because there was money available, there was a very good willingness and investment from governments and from multinational pharmaceutical companies in developing these vaccines. A lot of these phases were done in parallel to try and expedite and shorten the time of development. So instead of taking the usual 7 to 8 years to get to a vaccine, it took just under a year. And all safety and efficacy monitoring systems have remained in place. There is ongoing adverse event surveillance and monitoring, and there will obviously be continuous long-term follow-up once the vaccine has been marketed, which is what we refer to as post-marketing surveillance. So what we have seen with the coronavirus infection, because of this great scientific knowledge sharing, initially from the Chinese scientist who discovered this the virus in Wuhan in China, who within a month the sequence was known And once the sequence of this virus was known, or the genome blueprint was known, it was easy to use that blueprint to develop vaccines using these molecular biology-driven methods of vaccine development. So it took from when that virus was sequenced in January 2020, the first vaccine could be ready for clinical trial in March, and progressed because a lot of trials were done parallel in different centers. Phase 3 trials started in May, and the evidence that came was convincing that these vaccines were effective in preventing infections. So currently, as it stands today, I think we have about 3 vaccines that are registered under emergency use, and including 4 if you're counting the Russian Sputnik vaccine, which has also been introduced. And at various stages of clinical trials, we have in excess of 70 vaccines that are in clinical phases of trials. So to try and also, I'm seeing the questions that are being raised. I'm hoping that at the end we will have a Q&A session and we will answer those questions. So in this slide here, like I said, there was vast scientific information sharing, and there were various approaches that were put on to try and develop a vaccine fast, using all the known methods that have worked with other vaccines that we're using. So take, for instance, here, consider the central figure here to show what a virus is with its genetic material in the center and its little attachment proteins on the surface. So different vaccine companies here, we have used different parts of the actual virus to try and form a vaccine using different parts. Others have used the entire virus by attenuating it in culture. Obviously, that takes time. That is why we're not seeing any live attenuated virus being ready for registration yet, because that has to be grown in culture over time. Others have done the traditional approach of taking the whole virus, inactivating it using chemicals so that it cannot cause illness. Obviously, because that requires growing the virus in culture, we're not seeing a lot of those currently entering market. But those vaccines that rely on using genetic material know-how, or the blueprint of the virus, have been in the forefront of reaching a market stage, because as soon as you know how the sequence of the gene or the blueprint, it's easy to use existing a system to develop what we call nucleic acid-based vaccines, using either the RNA, the messenger RNA that instructs the body to produce the proteins that the immune system sees, or using DNA vaccines also that eventually results in an instruction being given to the cell. So we're seeing that these are the leaders. The Pfizer vaccine and the Moderna vaccine are the messenger RNA vaccine that are in the forefront, because those are easier to produce using molecular biology-driven methods. What has also been seen to be in the forefront is those vaccines that use sort of hitchhiking or a vector-based system of another virus which can enter the human system but does not cause disease. It's either not able to replicate or is not able to cause disease. Using that to introduce also the genetic material that will instruct the host cell to produce these proteins that the immune system will see, and once it sees that, it produces antibodies that make that vaccine protective. And that is what has been done by the AstraZeneca Oxford vaccine, which has been approved in the UK, And also the Johnson & Johnson vaccine has followed that line of development, and a few others. So basically, this is also to say that it's not like one method has been used. Different methods have been used, but all with showing a similar promise in the vaccine development and efficacy in the vaccine development. So as it stands today, these are the 4 vaccines that currently have received emergency use authorization. And like I said, these are nucleic acid-based vaccines, the Pfizer vaccine and the Moderna, and they've shown very good efficacy, over 90%, on average 95% efficacy for both. The vector-based vaccine, which is the Oxford vaccine, is also showing good efficacy, over 90%, depending on the dose that's being used. And then there's also the Russian vaccine, which is also using a vector-based system. It has been registered for use in the Russian Federation, but I am not sure. I think there are still trials being done in South America and various parts of the world to try and get bigger numbers and to see reproducibility in the success of this vaccine. So like what I think the MEC said in the beginning was that vaccines have been used over a long time, and we know they work, and we know they are safe, and we use them with our neonates, with our infants, with good effects, with our young people to protect them as they grow. And another great vaccinologist, Dr. Stanley Plotkin, who came up with the Rubella Vaccine, which prevents German measles, which causes devastating fetal loss and fetal malformation in pregnant women. He said that with the exception of safe water, there has been no other modality, not even antibiotics, has had a major effect on mortality reduction as well as in improving population growth and life expectancy. So in closing, I think I'll just, I've tried and found in various media platforms the current myths that are prevailing, that people have seem to have concern over regarding the COVID vaccines, and to try and answer those questions and allay the cause of hesitancy. The first myth that I've seen is that because the COVID vaccine has been rapidly developed, it is not safe, it is not trusted, it hasn't been given enough time for testing. So for that reason, people are worried. What we know for sure is that we haven't had a pandemic in a long time, like we have COVID. And the emergency situation of the COVID-19 pandemic warranted an emergency response and warranted thinking out of the box and throwing all our arsenal of ammunition against the fight against this severe pandemic. So there was a worldwide impact, and with that came willingness from many pharmaceutical companies and governments to invest significantly, like we have not seen before, that money can be made available so fast, so quickly into drug development or vaccine development. So that was a plus. And that's the reason really that this vaccine has been available so fast. We're building on known knowledge. We also had willingness where it matters as far as financial investment is concerned. And then the second myth I've seen is that there are very severe side effects of COVID-19. I think I've seen some videos of people having jerky movements and looking epileptic like minutes after receiving a vaccine. Obviously, this is, I'm assuming it's meant to just be funny, and unfortunately, some people take such videos to heart. We have seen through early phase studies that these vaccines are safe. We're not saying that there is absolutely no adverse event. any vaccine and anything that is ingested may cause some sort of an undesired effect. What has been observed is, like currently existing vaccines, is that there are short-term mild reactions like pain around the site where the vaccine was inoculated, or a transient fever or flu-like illness. Similar, we've all observed a baby after receiving their inoculation that they're a bit groggy for that day, and then they're fine afterwards because the immune system obviously is responding to an allergen. So the safety definitely is there, and the risk does not outweigh the benefits of the vaccine. The next myth is that the COVID vaccine was developed to control the population. There is some belief that because these are nucleic acid vaccines, I don't know, maybe it's the technology movies that we have seen, people believe there is tracking or microchips that are put into the vaccine. Like you have seen in the illustrations I showed before, there is no vaccine microchip that is put into a vaccine, and a vaccine will not track people's movement or will not gather any personal information. It's just not that advanced. There's another belief, obviously, because these are RNA and DNA or nucleic acid-based vaccines, that when they enter the body, they will alter a person's DNA. This is far from the truth. The mRNA vaccine, all it does is it instructs your own cells to produce the spike protein, which the immune system sees. And as soon as that happens, that mRNA, the body has its own inbuilt systems of degrading and disposing of that mRNA. So the body will get rid of the mRNA through the natural degradation systems once that instruction has been carried out. So there is no worry of integrating into the human DNA and changing the DNA in whatever form. And then there is the one about people who have egg allergies, feeling that because they are allergic to eggs. Previously, we've had issues of vaccines that are developed in eggs, and people with egg allergies may have received a warning to not use a vaccine that was developed in chicken eggs. And none of the currently used vaccines have been developed in these egg-based culture systems. However, there is, like any drug, when it is given to a person with a history of known severe allergic reactions, such people are encouraged to remain in observation for at least 30 minutes to an hour after the vaccine has been given, to make sure that they do not suffer any severe allergic reactions. What is still not known, and what is an area of ongoing research, is obviously the question that has come up now with the new variant that has come up, that has been detected in various countries, including ours, is that are the vaccines, because they were developed before the variant was detected, will these vaccines work against these variants? This remains an active area of research, but there is promise that because of the different types of vaccine strategies, that the vaccine will work. Some papers have come up again that showing that the vaccines have shown success, but it remains an active area of research, and I cannot confirm how well it will work against the variant at this point. Another unknown issue, because this is a relatively new virus, is how long will the protection last? Will we need a booster like we have for the flu vaccine every year? This also remains an ongoing monitoring and an ongoing area of research, and we'll only know in due course how long the protection lasts. And while we're waiting for that to happen, we do the basics. We stay at home, we wash our hands, we sanitize, and we observe all hygienic measures to make sure that we are protected from transmission and acquisition of the coronavirus, causing coronavirus disease. Thank you very much. I think that is the end of my presentation. I'll hand over to the program director.
Thank you. Thank you, Dr. Msomi. Thank you for the detailed coverage of the topic. We had said that we're going to allow people to have questions and answers and some engagements. I think you've taken us through almost everything that we need to hear about the virus. I just want to go through only 3 things that I've seen on the chat box. Mapisa will assist me if there's more that is coming or hands that are coming. But one person, Sindimkunu, is asking a question that says, what is the major component of this vaccine? Did not explain as to whether is he speaking to just the ordinary ingredients, the carriers of the vaccine, or the RNA, DNA aspect. I think we'll just speak a little bit to both. The other 2 people, that is Dr. Kumete and Promilda, if I call the name wrong, apologies. They are wondering if this presentation will be shared with them after this presentation. The last question is one that says, is this vaccine for prevention and treatment? Is it for both or is it for one of them? Those are the questions I have so far, and I'm going to ask that you delve into them while we check with Ntokozo if there are more hands and there are more engagements. Ntokozo, you will indicate. Thank you,
yes.
Doctor.
Let me request to Doctor to bring back my powers, because I can see some hands here so that I can able to allow the people to speak, to ask their questions.
Let me answer the question.
Another question came in, and it says, when will KZN be getting the first doses of the vaccine? If I get vaccinated, does it mean that I won't be infected in future? It's another question. So those are the ones that I have so far. I think you can delve into that, Dr. Thank you.
Thank you, Dr. Tshabalala. So on the first question by Sindimkunu, asking what the major component of the vaccine is, the major, like I had said, different approaches are being used in developing different types of vaccines. So no, they're not all the same. But for those that are currently registered, they are focusing on creating an immune response against the outer spike protein. So the main component is either the mRNA that instructs the host cell to produce the spike protein, because that is what the immune system commonly responds to in generating immunity. So that is the main ingredient. But it obviously varies depending on what type of vaccine we're dealing with. The next question was regarding whether this vaccine offers both prevention and treatment. It's currently being aimed at prevention. I have not yet come across any study where it was used in sick people showing efficacy in treating. So I don't think it is currently being touted as a therapeutic vaccine, but mostly for prevention. And another question that follows through from that is, will a vaccine mean you won't get infected in future? That, like I said in I think the penultimate slide, is that it's an ongoing area of research. We're still trying to establish, researchers around the world, establish how long the immunity lasts, and if the immunity will protect against all different types of lineages or variants or strains, whatever terminology people use. So that is currently an ongoing area of research.
No, I wanted to check whether can you take the hands of the people that are there, because I'm struggling on my side to, my powers are not back yet. If is it possible for you to check the hands there?
Okay, I'll start with ENCA Durban.
Yes.
Hi, Doc. So my question is around the myths of 5G technology. I just want the MEC to basically share with us some of the dangerous things that can happen if people continue to spread this fake information.
Hi, Doctor. Perhaps this is more a question for the HOD or MEC. I'd like to know about the actual vaccine rollout, especially for healthcare workers, considering KZN does have the highest number of active cases and we're seeing more health workers being infected. If we can just push this in, because we have been trying to ask this question, what contingency plans are there right now as healthcare workers getting infected? If you can please assist us with that and the rollout of vaccines for our province's doctors and nurses. Thank you.
Thank you. Winnie Baphumelele Cele.
Hello, can you hear me?
Yes, we can hear you.
Okay, sure. Thank you, Doc. My question is, thank you for the presentation. My question is, the rollout, has it been done? Anyway, it came late, if maybe that was answered on the presentation before. Has the rollout been done on other countries? And if yes, what are those, which countries are they? And how was the response that is on those that they've already got the vaccine? How was the response, especially of side effects? As much as when Khanya was presenting, she has touched some of the side effects, but the correcting those major side effects, how long will it take? Because that's what makes our communities, our societies to be very much afraid of the virus. I mean to say of the vaccine. So how do we correct that? If, for instance, the side effects developed immediately, and then what do we do? And secondly, how will the rollout be done, especially in KZN, and how do we ensure that the mind state of people it's in a correct state? Thank you.
Yes, they're clear. I think the main three questions from the three previous speakers was regarding the rollout, so I'll defer that to the Ministry of Health. On the question on on which countries have rolled out the vaccine, we have a few countries that, remember, these vaccines have been authorized for emergency use since December. In the US and more recently in the UK and a few other countries. And the first phase of rollout has been predominantly to frontline healthcare workers and as well as other frontline workers that were targeted. The response from what I see in the media is good. As far as adverse events or severe adverse effect, I have not seen the scale of severe side effects that I was jokingly saying that people get jerky movements that are being touted around in social media platforms. But in cases where you're getting what we call an anaphylactic reaction, those would have been observed and addressed like any anaphylactic reaction or an allergic reaction using existing medical tools to address any allergic reaction. Because such a reaction is a medical emergency. But suffice to say, these have been very rare events indeed.
Yeah, I would like to respond to the question of the rollout. When is it going to be, or how is it going to be done in the province of KwaZulu-Natal? As I indicated, the minister is expecting at least 1 million vaccines to be brought into the country in February, and those are going to be distributed amongst the healthcare workers first. But as soon as they have been brought in, we will then be able to indicate which areas first and where healthcare workers are going to get their vaccine. But right now we are waiting for the vaccines to come into the country, and then we'll be able to implement. Like I indicated earlier on, we do have a plan, and as soon as it looks like it's imminent for the vaccines to get into the country, we'll then be indicating and give you a proper detailed plan on how we are going to distribute them. But as indicated, the first people that are going to receive the vaccines are those that are in the front line. Thanks.
MEC, I've heard some of the questions as well on the chat. One of the questions is KZN the epicenter of COVID? The other question is, did KZN reach the peak of the second wave? During trials, did people get sick, and what percentage? I think that goes to Dr. Msomi. The other question says, when will the vaccine be rolled out? MEC has spoken to that. And in the meantime, what are the contingency plans? I think Dr. Msomi, you spoke to that when you were presenting in terms of all the precautions. The rollout has been answered. The last question that Dr. Msomi spoke to. I am not certain whether MEC would like to speak to these other questions. We'll take it from the MEC. May I give you the opportunity? If there is any you want to tackle of these.
We also do have some, sorry MEC, we also do have some questions from the Facebook page. We have Veli Vagan Williams, who says, how is it possible to safe conduct preclinical and clinical trial phases at the same time? And Uzinhle Ndimeni, what if the mutation occurs in my body, like how the virus mutated? Utulile Biela, vaccination of people who have previously tested positive for COVID-19. Can I get clarity? And then there's Lindy Lemien, who says, Great Town Hospital, will people that were previously infected benefit from the vaccine, and will it assist them? Eric Dube, where are the Cuban doctors and the team? How far they've gone with their duty calls here in SA? Okay, that's another. But there are a number of questions on Facebook page there, MEC.
Let me start with the Cuban doctors first, because it's easier to deal with. We received a contingency in the country of more than 240 Cuban doctors. They were distributed along the 9 provinces. As the province of KwaZulu-Natal, we received 26 of those Cuban doctors. What we did amongst ourselves, we then distributed all the 26 professionals in the 11 districts that we have. Each and every district has 1 or 2 of the Cuban doctors assisting, particularly in the COVID or in facilities that we have termed as the COVID side. So we have seen quite a lot of work being done by these compatriots, and I think we should appreciate or we should continue to appreciate the generosity of their country and the generosity of the people of Cuba by volunteering to come and assist us. We have benefited a lot as a province from the work that they have done and the work that they continue to do in the province. Some of the specialists that are within the Cuban team was including the issue of epidemiologists, which we didn't have a lot of in the province, and they have contributed and assisted us. So they are there and they are working in the different districts. And the good thing about them, they also do not mind at all actually being sent in the different regions or districts, including the rural parts of our province. Can I then respond? I think the question that I would want to deal with is the one that says, are we an epicenter as the province of KwaZulu-Natal? I'm not sure what informs that question, but let me just give you the statistics. According to the statistics that we have been given by the National Department of Health, in terms of the infections that we have had in the country, the highest province in terms of infections right now is Gauteng, and they have 338,000 infections, followed by the province of KwaZulu-Natal with 255,000 infections, followed by the province of the Western Cape with 643,000, followed by the Eastern Cape with 181 infections. Now, these numbers of the infections in KwaZulu-Natal in particular have gone up just in the past 2 weeks. Late November, early December, as a province, we were number 4 in terms of the infections in the country. And we were surpassed by the Eastern Cape and the Western Cape. So safe to say that the issue of infections is something that is fluctuating. It depends on who has the wave at that particular time. The wave started with the second wave started with the Eastern Cape in this case, and the Eastern Cape went very high in terms of their infections. It went to the Western Cape, they went high, and subsequently it came to us, and it looks like it's going to be moving to Gauteng in a couple of days or in a few weeks' time. So are we the epicenter? Well, I don't believe the numbers are saying so, but should we have numbers that are exceeding everyone in the country, I think then we will become the epicenter. Is there another question, Dogoso, that I have not responded to? The majority of the questions are needing a specialist, Dr. Msomi.
Thank you, MEC. I think the question that I would like to address is regarding whether the vaccine would work in previously infected people who've had COVID before. Like I had said in one of the slides, that an ongoing area of research is how long the immunity lasts. And because that is not yet known, I would think that would inform, once that is clearly known, on how naturally acquired immunity, how long it lasts and how protective it is, or how widespread it is against different variants. That would inform whether the vaccine is given to people who have had previous infection before. But for now, I don't think that decision has been made. It also speaks to the point on whether the vaccine is being used as a therapeutic vaccine. I've already answered that question. I think that was the main technical question that was on my side regarding vaccinating people who have previously tested positive.
Is it possible to take the hand from Nkosi Khona? He's been trying to talk to us.
Oh, yes, Nkosi Khona. You're allowed to talk?
Oh, yeah. Hi. This is Nkosi Khona Duma from Eyewitness News. I just have questions directed to the MEC. MEC, last night we actually saw that the cases in KZN, there was a massive drop in active cases. I think the day before, the National Department of Health reported that there were 93,000 active cases in KwaZulu-Natal. Yesterday, we saw that figure had been lowered to about just over 66,000. Can you just advise us as to what's led to this sudden decrease? Does this mean that the province is, in a way, now surpassing a peak? And can you just give us clarity about how your department is really modeling its peak during this second wave? Thank you.
All right. Thank you very much, Nkosi Khona. Well, I'm glad it's you who's asking this question, because 2 days ago I was with you and we were talking about the same issue of the recoveries. And I indicated when you asked the same question that the issue and the reason why our recoveries were so high was because at one given time, say about 7 or 14 days ago, as a province, we received, we got, in 2 days, we got more than 10,000 infections. And we, in the following 2 days, we also received another 10,000, give or take, infections. Now, I indicated to you that though people are then considered to have recovered 10 days after they had been tested or have started their isolation. So the reason that you see we have dropped with about 20,000 or 30,000 numbers, it's because those that had actually gone out of isolation, something that is a serious worry or a worry at all, in fact. The issue here is that we had a big number of patients who were infected in 2 days or 3 days, and all of those, when they exit, they will then eventually exit around the same time, or the majority of them will exit around the same time, with the exception of those that are still in hospital or that are being treated in our own facilities. So that explains, it is actually in line with what we spoke about, you and I, a couple of days ago when we were discussing the issue of recoveries. What was your second question, Koskon? Or the issue of the peak?
Of the peak, yes.
Yeah. Look, at this point, we don't want to preempt whether we are past the peak or not, because scientists are working on the modeling and they're going to come back to us. However, what we have noticed, and it's something we need to indicate, is that the number of infections in the past 4 or 5 days has dramatically gone down. Whether this is us being past the peak or it's just a slump for a couple of days, we are not sure. As soon as we have the proper scientific research, we will then be able to indicate and speak to that. We also don't want to preempt the work that is being done by scientists and make pronouncements that are premature when we've actually not been given the proper research. All we know for now is that our numbers in the past few days have gone down. Whether it's us plateauing or it's just a slump and we're still going to go back, at this point we are not sure.
Maybe the last word from Dr. Msomi, last word from MEC, then we close.
Thank you very much, Dr. Tshabalala. I hope, thank you very much for all the questions. I hope we have tried to answer them, and those that have not been directly answered, I'm sure can be forwarded through Mr. Mapisa and can be answered after this webinar is over. I hope this was an informative session and beneficial to the community at large and to colleagues, and we look forward to engaging with colleagues and community and sharing information that is factual, and to try and get the buy-in of those of us who remain hesitant against measures to control the coronavirus pandemic in our country. Thank you very much.
Thank you, Dr. Msomi. MEC?
Thank you very much, HOD. Thank you very, very much to Dr. Msomi for giving us this opportunity and for ensuring that she gives us a presentation that is very clear, a presentation that is easy to follow, a presentation that most of us will understand. There is a comment that we saw earlier on that was saying this presentation or this session is long overdue. I think I do agree with that. We should have done this particular session probably last week, but it's never too late. We have provided the information now. We are hoping that on Friday we will provide the same information in isiZulu, so that those that are following us in isiZulu also get an opportunity to engage with Dr. Msomi and ask questions that are pertinent from her, so that they also understand in detail what do the vaccines actually entail. There is another question that was saying I should speak to the issue of the 5G. I would want to speak to it, but I think it is proper for me not to talk to it for now, because I know the Premier is having a webinar, like I indicated earlier on Friday, that will strictly be talking to 5G, and it will have IT specialists that are going to be speaking to it, and will probably send 1 or 2 people who are clinicians that will then explain the link or the fact that there's no link between 5G and what we are faced with in relation to COVID-19. With those words, I really appreciate the work that has been done by Dr. Msomi, Usizeka Kulu. I appreciate everyone who has participated in this forum. We hope that with the information you have received, you will be able to go out and talk to our communities, talk to our families, talk to our friends and neighbors about the vaccine, about the fact that this is something that actually might save our lives, and clarify all the myths that are out there. And thank you very much for participating. Thank you very much, HOT, for being our program director, and Togozo for hosting us. Siyabonga.
Thank you, MEC. Now, MEC, you've spoiled my thing. I wanted to sing the song that says Shumaye Livangeli, and you already have said the words in that song, so I'm not going to sing anymore. I think I will just have to thank you, MEC, for making the time. I may tell the community that this is your 4th meeting today, and you already are late for the next meeting, which is starting at 1 o'clock. For the hard work that you are putting in, thank you so much. Thank you, Dr. Msomi, for availing yourself, and thank you for availing yourself as well on Friday to explain this further. We're hoping that, as MEC says, the correct information will be given to the people of our country through the media and all the other sources of information. But thanks everybody who was attending and who contributed in one way or another. Tokozo, thank you. Intambo ihlale zikuwe asizuyibanga nawe mfowethu. Ungayithatha nje ngiyakupha futhi. Thank you, MEC.
Udokotela uyithathe zonke namhlanje. Hayi ke usuka sivalela dokotela ngapha entanjeni. Siyabonga. Thank you very much.
Thank you very much. Bye-bye.
Thank you very much. Bye, Dr. Msomi.
Bye-bye.